Are in listen-only mode.
Hello, everyone, and welcome to today's webinar, a continued conversation on the maternal and fetal consequences of rare bleeding disorders, Fibrinogen deficiency, Factor XIII deficiency, and inherited platelet disorders. My name is Kerry Funkhouser, and I am the Director of Education for the Foundation for Women and Girls with Blood Disorders. I will be moderating today's webinar. Next slide, please. The Foundation for Women and Girls with Blood Disorders' mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide, please. Today's presenters are Dr. Meera Chitlur, who is the Barnhart-Lusher Hemostasis Research Endowed Chair, Director of the Jean Lusher Center for Pediatric Hemostasis, Thrombosis, and Special Coagulation Laboratory, and a Professor of Pediatrics at Wayne State University School of Medicine and the Children's Hospital of Michigan. She is joined by Dr. Madhvi Rajpurkar, who is the Director-Chief of Hematology and a Professor of Pediatrics, as well as the Director of the Pediatric Thrombosis Program at Wayne State University and Children's Hospital of Michigan. Next slide, please. The Activity Medical Director for today's webinar is Dr. Andrew James from Duke University Medical Center, and our planning committee for today's presentation includes James Munn and Dr. Barbara Alving, Barbara Conkle, Roshni Kulkarni, Kenneth Mann, Evelyn Lockhart, and Jennifer Dietrich. Next slide. In accordance with the Creighton University Health Sciences Continuing Education Policy, the Faculty and Planning Committee for today's webinar have disclosed any significant financial interests or other relationships of interest relative to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of the information presented in the lecture. You may learn more about this at the Foundation's website, fwgbd.org. Next slide, please. To ensure the best sound quality during the webinar today, all attendees will be muted during the webinar. However, all attendees will have the opportunity to participate in a question and answer session with the instructors at the end. You can submit your questions during or after the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen. We gladly welcome your input. Next slide, please. This learning activity is offered through the Creighton University Health Sciences Continuing Education Program, which has been accredited for the offering of 1 AMA PRA Category 1 credit for physicians and 1 contact hour for nursing professionals. Next slide, please. The following are the learning objectives for today's webinar. For those who wish to refer to these later, we will record and archive this webinar on our website. I will now turn the presentation over to Dr. Meera Chitlur. Next slide.
Good afternoon, everyone. I'm Meera Chitlur, and I'd like to thank the Foundation for Women and Girls with Blood Disorders for having me here today, along with Dr. Rajpurkar, to discuss with you the maternal and fetal implications of inherited deficiencies of fibrinogen, factor XIII, and platelet dysfunction. To start with, I'll briefly touch upon the relationship between the placenta and the hemostatic system, and followed by a discussion on congenital fibrinogen disorders in women and adolescent girls. Dr. Rajpurkar will then talk to you about factor XIII deficiency and platelet dysfunction. So inherited bleeding disorders have lifetime implications and result in significant morbidity and mortality. The clinical features can be extremely variable, and diagnostically it's usually challenging as well. Pregnancy, labor, and delivery represent significant hemostatic challenges in women with these bleeding disorders and require individualized treatment plans that are developed by multidisciplinary teams. While our understanding is improving significantly, these patients are underrepresented, understudied, and in dire need of systematic guidelines for management. Sorry, I'm having trouble with my mouse. There you go. Okay. So today we'll talk about, we'll touch upon the brief relationship of the placenta with the uterus. And I must tell you that this presentation was given by Dr. Diane Nugent at the American Society of Hematology meeting. She's a fabulous speaker and renowned hematologist, and her presentation is available on the website for anybody that's interested in listening to her. I would definitely encourage you to do that because I don't profess to be anywhere close to what she did at the meeting. So in terms of the unique relationship of the placenta and the uterus, one of the interesting things is that platelet dysfunction, factor XIII deficiency, and fibrinogen disorders lead to miscarriages that occur very early in the pregnancy, typically in the first trimester, although they can occur at any time. Why is this so? Does this really give us a clue? Let's see if we can find some answers. So fertilization occurs about 24 to 48 hours after ovulation takes place, and the fertilized ovum or the zygote then multiplies into a mass of 12 to 16 cells called the morula. This is encased in the zona pellucida and travels through the fallopian tube. That journey takes about 2 or 3 days, and the embryo is then transformed in this process into a blastocyst and enters the uterine cavity, where it actually hatches from the zona at the site of implantation. So even though we are Homo sapiens, we still hatch. The second figure actually shows you the next step, which is implantation. Next slide, please. So this diagram shows the blastocyst in the pre-implantation stage. Several changes occur to facilitate the opposition, and there's significant crosstalk between the endometrium and the blastocyst. As you can see, several cytokines and growth factors are released to facilitate the changes that are necessary for implantation. Microvilli are actually formed on the syncytial trophoblast and interdigitate with the pinna pods on the uterine epithelium. Once the blastocyst is stable and adhered to the uterine epithelium, the syncytial trophoblast then begin to invade and penetrate the uterine epithelium. And by the 10th day, the blastocyst is completely embedded, as shown in this picture. And the cytotrophoblasts have actually invaded the endometrium and the myometrium and uterine vasculature and result in the establishment of the uteroplacental circulation. Transcription factors, growth factors, and cytokines that are produced by the endometrial glands play a very important role in maintaining the health of the blastocyst. Next slide, please. In 1961, Pritchard reported the association of placental abruption in hypofibrinogenemia. His hypothesis was that minute placental separations and hemorrhages occur in normal pregnancy and that are controlled by the conversion of fibrinogen to fibrin. And in its absence, this leads to abruption. Subsequently, rabbit studies and mouse models have shown that it is that the mice can actually establish a normal hemovascular system and complete embryonic development without fibrinogen, but they're unable to sustain the pregnancy because of exacerbation of the hemorrhage that occurs as the embryonic tissue invades into the decidua. This process starts at about day 6, and in the absence of fibrinogen, there's accumulation of large amounts of blood in the lacunae, leading to detachment of the placenta from the endometrial tissue. In addition, it's also known that fibrinogen actually induces proliferation of the trophoblast. Although this mechanism is not very clear, it's possible that tissue transglutaminase or factor XIII cross-linked fibrin binds to the cellular integrins and influences cell spreading and proliferation through growth factor signaling. Therefore, when there's impaired fibrin formation, and as is seen in afibrinogenemia or factor XIII deficiency, there is a very early loss of pregnancy. While we're discussing these issues with bleeding, it's also important to note that excessive fibrin deposition is also associated with pregnancy complications and preeclampsia. So studies have shown that there is a feedback mechanism where tissue factor expression on the trophoblast is limited by fibrin accumulation, and so there's downregulation of the procoagulant process. It suggested that protein C and TFPI are involved in this process, and TFPI expression is actually noted in the trophoblast as early as 10 weeks of gestation all the way to term. So you can see that fibrin is deposited in several spaces, and so this delicately balanced deposition of fibrin allows placental remodeling and influences pregnancy outcomes. So let's talk about fibrinogen deficiency and dysfibrinogenemia. So inherited disorders of fibrinogen are rare, and they can be subdivided into type 1 or type 2 disorders. Type 1 refers to quantitative defects, which are primarily referring to afibrinogenemia or hypofibrinogenemia, and type 2 refers to qualitative defects, such as dysfibrinogenemia or hypodysfibrinogenemia. Megakaryocytes and platelets can also internalize fibrinogen via the glycoprotein 2B3A receptor, and therefore, if the platelets also lack fibrinogen, these patients have a much more severe phenotype. Next slide, please. So fibrinogen is the most abundant clotting factor in the human circulation. So the concentration is about 1.5 to 3.5 grams per liter, or 150 and 350 milligrams per deciliter. It's a 340 kilodalton glycoprotein, and it's synthesized in the hepatocytes. Structurally, it has two D regions or domains, which are on the outside, and a central E domain, which is connected by coiled connectors. Each molecule has two sets of 3 polypeptide chains, A alpha, B beta, and gamma. And they're joined to form the E region. And fibrinogen actually has a very long half-life of about 4 days. Next slide, please. There are 3 genes that encode fibrinogen on chromosome 4. Single chains are translocated into the endoplasmic reticulum, where they're assembled. The protein then undergoes several post-translational modifications in the Golgi complex. Transcription of each of these 3 genes is upregulated by 2 to 10-fold in response to stress, such as inflammation, tissue injury, or even pregnancy, via the glucocorticoid and IL-6 pathways. To date, the mutation analysis of the fibrinogen molecule has not revealed any correlation between phenotype and ethnicity, but it's still valuable for diagnostic confirmation of the diagnosis and also for identification of carriers and in the case of prenatal diagnosis. It's, however, extremely valuable in patients who have dysfibrinogenemia, as some of these mutations are known to predict a bleeding phenotype, while others predispose to thrombosis. Next slide, please. So the clinical manifestations vary according to the type of deficiency that is seen. Afibrinogenemia, since it confers a complete lack of fibrinogen, has the highest frequency of bleeding. An Iranian study that Dr. Pevandi reported showed 85% of these patients had umbilical cord bleeding, 72% had muscle hematomas, but more than 70% of these patients actually had menorrhagia and mucous membrane bleeding, such as epistaxis and oral cavity bleeding. Dysfibrinogenemia, on the other hand, tends to be much more variable. About 50% of these patients are usually asymptomatic, but 25% report bleeding and 20% can report thrombosis. Hypofibrinogenemia patients tend to have very mild symptoms with bleeding mainly post-trauma. Dr. Pevandi actually analyzed the European Network of Rare Bleeding Disorders registry and reported that the bleeding manifestations did correlate with the fibrinogen activity. And she found that patients who had fibrinogen levels of greater than 100% tended to be asymptomatic, whereas those that had levels less than 70% tended to have more significant bleeding. The grading of bleeding was done as seen in this table as grade 1, 2, and 3, where 3 refers to spontaneous major bleeding episodes such as intracranial hemorrhage. Grade 2 refers to spontaneous minor bleeding episodes such as epistaxis or gum bleeding. And grade 1 refers to bleeding in response to trauma or ingestion of drugs only. Next slide, please. So in order to establish diagnosis of dysfibrinogenemia or afibrinogenemia, it's important that we correlate the bleeding symptoms, the phenotype, and we require a combination of routine coagulation assays such as PT, PTT, thrombin time, as well as antigenic assays and functional assays. So demonstrating the molecular defect is usually, as I said before, helpful to confirm the diagnosis. So since all of the screening coagulation tests, such as the PT, the PTT, the thrombin time, and rhabdolase time, are dependent on the conversion of fibrinogen to fibrin, all of these tests are abnormal when tested in patients with these disorders. Subsequent testing will depend on whether we are suspecting hypofibrinogenemia or dysfibrinogenemia. In a very nice paper, which is the figure from on evaluation of dysfibrinogenemia in blood, shows that these assays are not necessarily, the screening assays cannot predict the phenotype. So the assessment of genotype may help in certain situations, especially such as dysfibrinogenemia, because we know that some mutations are thrombotic and some result in bleeding. But maybe the newer assays and that are done mostly for research still, and global assays such as thromboelastography actually can help us correlate the phenotype with the genotype of these patients. Next slide, please. So here's an example of a child that presented to us at 3 years of age with recurrent epistaxis and a family history of bleeding. Her mother had significant heavy menstrual bleeding and postpartum hemorrhage requiring transfusions. Her routine coagulation studies were already abnormal, suggestive of a hypofibrinogenemia, and gene sequencing revealed a new substitution in the gamma chain, resulting in decreased gamma chain expression and hypodysfibrinogenemia. So we got to name this new variant as fibrinogen Detroit 2, and incidentally, the very first dysfibrinogenemia patient was identified in 1958 at Wayne State University in Detroit and was named fibrinogen Detroit 1. Next slide, please. So coming to the treatment of congenital fibrinogen deficiency, it's important to tailor the treatment in these patients to the severity of bleeding episodes that you can see. So non-transfusional treatments such as antifibrinolytics, fibrin glue, or hormonal supplementation should be considered in patients whose bleeding manifestations can be managed with these interventions rather than fibrinogen substitution. And substitution should probably be reserved for those major bleeding episodes or those patients who have significant spontaneous bleeding on a regular basis. Next slide, please. So this slide actually depicts all or shows you all the concentrates that are available currently all over the world. The only fibrinogen substitution concentrate that's available in the United States is Riostat, and is only FDA approved for patients who have afibrinogenemia and cannot be used for hypo or dysfibrinogenemia. Next slide, please. So fibrinogen replacement can be done either on demand or as a regular prophylactic substitution. A single dose of 60 to 70 milligrams per kilogram will give you a fibrinogen activity of 1.3 to 1.4 grams per liter within about 40 minutes to an hour. And the median half-life is about 3 to 5 days. So primary and secondary prophylaxis can be established for those who have significant spontaneous bleeding. So this table gives you doses of all the plasma as well as concentrates that you could use for management of patients who might be undergoing major or minor surgery or for management of spontaneous bleeding. Next slide, please. So treatment issues in women. So women with afibrinogenemia or fibrinogen abnormalities suffer from heavy menstrual bleeding and decreased fertility. And like we said before, the role of fibrinogen is to control normal bleeding events that are seen during development of the maternal fetal unit, and also to develop a stable fibrinoid layer that anchors the trophoblast to the decidua in terms of management of pregnancy. So in patients who have afibrinogenemia, it is recommended that we maintain fibrinogen levels greater than 0.6 grams per deciliter, and ideally to maintain it over a gram per liter. And during labor, it is recommended that these levels be even higher at 1.5 grams per liter to prevent placental abruption. In patients who have hypofibrinogenemia, these substitution or concentrates can be titrated according to fibrinogen levels and the bleeding history. In those who have dysfibrinogenemia, the management of pregnancy should be based on the personal and family history. Those who have a more significant bleeding tendency can be administered prophylactic fibrinogen replacements, but it's important to know that they may also require concomitant thromboprophylaxis. Next slide, please. So why is this such a challenging problem for providers? One is that the replacement in pregnancy must be started so early, within the first 4 weeks, and most of the time these patients may not even be aware. So it is recommended in some situations that if they are planning to get pregnant, to go on prophylaxis so that they would then be ready for this process. And it's also important because it's also important to remember that replacement with fibrinogen concentrates or plasma can result in thrombosis and pulmonary embolism. And the spontaneous thrombosis risk increases over time in those who have hyperfibrinogenemia, making management of these patients extremely challenging. Next slide, please. So Cassini et al. Looked at a multi-center study of 101 patients with congenital dysfibrinogenemias and tried to characterize the bleeding and thrombotic events and complications that were noted during pregnancy and surgery. They identified 111 pregnancies with an overall incidence of spontaneous abortion of 19.8% and postpartum hemorrhage 21.4%. The risk of postpartum hemorrhage was seen more in patients who already had a bleeding phenotype. Next slide, please. So why do we have this increased risk of thrombosis in patients who have fibrinogen defects? One reason is that the fibrin acts as a thrombin sink. So when you don't have enough conversion of fibrinogen to fibrin, then circulating thrombin, active thrombin, remains in circulation and continues to be a procoagulant state. And so that results in excessive thrombosis in these patients. In addition to this, improper fibrin polymerization, which can be seen in these situations, result in decreased response to fibrinolytic enzymes and inability to get rid of clots appropriately. The clot that's not appropriately formed also is not very stable and cannot attach to the endothelium appropriately, and therefore these patients are more susceptible to embolization of thrombi that they form. Next slide, please. So this is again the Cassini study that showed that the patients with dysfibrinogenemia had both arterial as well as venous thrombotic events. The incidence of all thrombotic events was much higher in these patient groups compared to others. The study actually concluded that patients with congenital dysfibrinogenemia carry a high risk of bleeding and thrombotic events and postpartum hemorrhage, but not spontaneous abortion. They didn't see that association. So one of the conclusions of the study was that ongoing prospective studies like the PRO-RBDD project will provide us with much more valuable insight into the clinical features and management of this complicated group of patients. Thank you very much, and I'll hand over the mic now to Dr. Rajpurkar.
So I guess there's a quick poll here. Andrew, I'm not able to advance the slides, so if you could please help me. Okay, so good afternoon. My name is Madhvi Rajpurkar, and it's my pleasure to present here today. In trying to prepare for this presentation, I have truly learned so much. First of all, listening to Dr. Nugent's talk was truly revealing. And as a hematologist, we take for granted that the role of clotting proteins is only restricted to clotting and bleeding. However, in trying to review the role of factor XIII deficiency, I have learned about what role it plays in many other functions in the body. And thank you, Meera, for that excellent review on the physiological changes that takes place during implantation and normal pregnancy. And this is exactly the prelude that we need to understand the role of many other coagulation proteins and platelets, and especially the role of factor XIII in pregnancy. Next slide, please. So Factor 13 is pro-gamma transglutaminase, which circulates in the plasma as a heterotetramer, and is made up of 2 A subunits and 2 B subunits. When the coagulation cascade is activated, thrombin is generated, and thrombin actually cleaves these 2 activation peptides from the tetramer to form factor 13 prime. And in the presence of calcium and the substrate, which is fibrin, there is a conformational change that takes place where the B subunits sort of dissociate from the tetramer, and the A subunits undergo a conformational change, and where the hidden catalytic units or the catalytic sites are exposed, and then they go on to cleave fibrin. Now, what's important to understand is that the function of factor 13 is varied, and it has functions beyond just the coagulation aspect, but it is important in the maintenance of pregnancy, bone metabolism, wound healing, and cardioprotection. So as I mentioned, the 2 subunits that are formed, the A subunit, the gene for the A subunit is on chromosome 6, and it is synthesized primarily in the megakaryocytes, platelets, and monocytes. On the other hand, the B subunit gene is on chromosome 1 and is made in the liver. And for a long time, we were sort of not aware of exactly the role of B subunit and just thought that this was a carrier protein. However, in the last few decades, we've come to understand that mutations in the B subunit can also lead to factor 13 deficiency, and its role is beyond just being a carrier for the A subunit. Next slide, please. So the picture depicts what happens and the role of factor 13 in forming a very stable fibrin mesh. And as is depicted here, factor 13 is important in cross-linkage of fibrin. And additionally, it is also important for anchoring of the alpha-2 antiplasmin protein to this fibrin. And as many of us know, the alpha-2 antiplasmin is also one of the most important antifibrinolytic proteins. So the net result is the formation of a very stable fibrin clot. And in the absence of factor 13, the clot that is formed is loose and friable. Next slide, please. So this is the repetition of the picture that Meera showed, and I think she sort of highlighted the fact that formation of fibrin is extremely important for implantation and maintenance of early pregnancy. And in here, maternal factor 13A subunits accumulate in the plasma, and we believe that the B subunit is actually important in ensuring that the A subunits get to the specific site, and therefore this function of A and B subunits is important for joining the maternal and fetal tissues. And this is important for stabilization of this fibrinoid layer. And in fact, severe deficiency of factor 13A subunit gives rise to a failure in the formation of the shell, leading to detachment of placenta and placental hemorrhage, and then spontaneous early onset miscarriage. Next slide, please. So this is another picture which depicts the same thing, and I just want to highlight this one area which shows that during normal trophoblastic differentiation, there are, as these placental fragments break off, normal hemostasis needs to occur at this juncture, and formation of a stable fibrin clot is necessary. So not only do we need other clotting proteins, but factor 13 and stable platelets are very necessary here so that placental disruption does not take place. Next slide, please. So this is representing the same thing. as I mentioned, factor 13 is extremely important in maintaining the fibrinoid deposits here, and cross-linking of fibrin and fibronectin is important. And I didn't know any of these layers, but I sort of now understand why this is important in maintenance of normal placental function. Next slide, please. So this slide depicts the role of factor 13 in tissue healing. And the yellow sort of pictures, yellow spots show where all factor 13 acts. And it is important in linking fibrin to collagen. It also enhances the aggregation of platelets and is important for platelet clot retraction. It also is important in formation of this matrix where all the cells such as the monocytes and the neutrophils get trapped, and then they are able to go on and function, which is important for wound healing. And also factor 13 is important for inhibiting thrombospondin, which is an inhibitor of VEGF, or vascular endothelial growth factor. So if in the absence of normal factor 13, VEGF decreases and we don't have enough angioplastic factors, and therefore normal blood vessel development doesn't take place, and therefore wound healing suffers. Next slide, please. So this slide summarizes the role of factor 13, and essentially it's important for fibrin cross-linking, angiogenesis, and then also the normal function of monocytes and fibroblasts. And it's thought that about 20% of patients who have factor 13 deficiency actually have poor wound healing. Next slide, please. So the hallmarks of factor 13 deficiency clearly are a bleeding characteristic, poor wound healing, and then pregnancy and postpartum complications. Next slide. So factor 13 deficiency can actually be divided into congenital factor 13 deficiency, acquired factor 13 deficiency, and autoimmune deficiency of factor 13. So the congenital factor 13 deficiency is a rare disorder and is thought to occur in 1 to 2 million population. It's an autosomal recessive disorder, and in this case, the typical level of factor 13 is less than 5%. The A subunit deficiency is much more common, but in the last few years, we have found that the B subunit deficiency does occur, and although rare, has been described. Acquired factor 13 deficiency usually occurs because of consumption of factor 13, and this may be because of presence of an external or an activating surface such as an ECMO, or being on a bypass machine, or in ventricular assist devices. Also, patients who have liver disease, Henoch-Schönlein purpura, may have acquired factor 13 deficiency. Usually in these cases, the factor 13 level is mildly or moderately decreased and may not be the primary reason that patients bleed, but the role is being investigated as to what is the contribution of this mild or moderately decreased level of factor 13 to bleeding post-ECMO or post-VAD placement. The third type of deficiency is autoimmune factor 13 deficiency, and both auto antibodies as well as alloantibodies, which means in patients who have congenital factor 13 deficiency and formation of an antibody against the transfused factor 13 may occur. However, by far, autoinhibitors are much more common and more commonly occur in response to the A rather than the B subunit. Next slide, please. So one way to categorize factor 13 is by categorizing it as type 1 and type 2. And in type 1, we have essentially decreased or absent factor 13A or B subunit, while factor 2, the protein may be normal, but may be functionally defective. The Europeans have also tried to categorize factor 13 deficiency into mild, moderate, and severe based on the 13 activity, and factor 13 activity of less than 5% results in spontaneous major bleeding, and as shown here, moderate deficiency is where the level is between 5 and 30% and may have spontaneous or triggered bleeding. And then we actually don't know what are the implications of having a factor 13 activity which are low but more than 30%. More likely than not, most of these patients are asymptomatic. Next slide, please. So this slide summarizes the various genotype defects that we have known, and so far about 69 mutations have been described in the A subunit, and about 16 mutations have been described in the B subunit. As I mentioned before, it is an autosomal recessive condition, so either patients are homozygotes or compound heterozygotes, and this usually results in severe disease with the factor 13 activity of less than 5%. More recently, investigations into patients who have heterozygous defects have shown that although the activity may be mildly to moderately decreased, this indeed may be associated with mild bleeding manifestations. Next slide, please. And this slide essentially shows that there are a variety of mutations that have been described, including missense, nonsense, as well as splice site mutations. Next slide, please. So as I said, the hallmark of congenital factor 13 deficiency is severe bleeding. And as can be seen here, the typical bleeding that is seen is an infant or a newborn who presents with umbilical cord bleeding. Now, the exact reason why patients have umbilical cord bleeding is unknown. However, it is speculated that this may have to do something with the trophoblastic tissue. The biggest and the most riskiest hemorrhage is the intracranial hemorrhage. And when you look at patients with all bleeding disorder, the risk and the severity is highest in factor 13 deficiency. And it is thought that up to 30 to 60% of patients who have severe factor 13 deficiency may present with an intracranial hemorrhage. It is also the main cause of death, and it also causes significant morbidity in patients with factor 13 deficiency. Now, what has not been understood or has not been realized is that patients who have factor 13 deficiency may actually have a very high rate of miscarriage. And anywhere between 50 to 70% of women who have severe factor 13 deficiency may miscarry at some point during their reproductive life. Next slide, please. So speaking of reproduction, this slide summarizes the levels of factor 13 during pregnancy. And as can be seen here, patients who these are normal subjects, and the level of factor 13 decreases during the first, second, and third trimester. And then in the postnatal period, it sort of improves, however, does not reach the normal level. And what has been shown and is currently being investigated is whether there is any association between factor 13 gene mutations, so polymorphisms and heterozygous state, and recurrent pregnancy losses. What this slide implies is that in normal pregnancies, the factor 13 level, in fact, does go down as the pregnancy progresses. And in patients who have factor 13 deficiency, it's very important to monitor the 13 level, and therefore the frequency of prophylaxis may actually need to be increased. Next slide, please. So it's important to realize that without replacement therapy, almost all patients who have congenital factor 13 deficiency will lose the pregnancy. So bleeding occurs without replacement therapy, and therefore prophylaxis is indicated. It is not needed for fertilization or early implantation, but is needed for the early placental health. And as I mentioned before, it is required for the proper anchoring of the cytotrophoblasts in the endometrium. And then the first case of a woman with a history of 12 spontaneous abortions was actually the first patient who we realized that this was important for replacement, and therefore this patient was treated with plasma transfusions every 10 days to end in a successful 13th pregnancy. Next slide, please. So this slide summarizes the gynecological bleeding and pregnancy outcomes in women with factor 13A or B deficiency. And I just want to, if you can click on the next slide button, please. I just wanted to highlight that in most symptoms are severe in patients who have the A subunit deficiency. So miscarriage is very common in patients who have the A subunit deficiency. Also ovulation bleeding as well as menorrhagia. But if you click on the next slide button, yeah, you can realize here that for some reason, patients who have the B subunit deficiency have early incidence of, higher incidence of antepartum hemorrhage as well as postpartum hemorrhage. And we yet don't know why this is so. So there's much investigation and much research that is needed in this area. Next slide, please. So the diagnosis of factor 13. Again, I always tell this to our residents. It is important to remember and think of factor 13 deficiency as a differential diagnosis because all routine coagulation tests, so your PT, APT, T levels, are normal, and therefore a high index of suspicion is needed. So once we suspect that factor 13 deficiency is a possibility, the most common test that is done is a 5-molar urea clot lysis assay. And essentially what happens in this test is a clot is formed by activation of the clotting cascade, and then it's subjected to either 5-molar urea or 1% monochloroacetic acid. And at the end of 24 hours, the clot is assessed and compared to a normal clot to see if the clot has lysed. So as this is a qualitative test, it detects factor 13 activity, which is only less than 5%. So although it may be a good screen and it's easily available, it does miss many patients where the level is more than 5%. So the specific way to diagnose factor 13 deficiency is to actually do a quantitative factor 13 activity, and this is measures the amount of ammonia that is released by a reaction which is responsible for the cross-linking function of factor 13. And this is a very sensitive, simple, rapid, and reproducible assay, and is commercially available in the United States for testing. And the range of testing can be as low as 0.1 to 400%. So there's a wide range that of factor 13 level that this can accurately and sensitively test. Now, once the factor 13 deficiency is diagnosed, the next step to do would be to do a factor 13 antigen. And one would then test for both A2 as well as B2 subunits, so the total antigen. And if that is found to be low, then tests should be carried out specifically for the A2 subunit and for the B2 subunit. This should then be followed by testing for a factor 13 antibody, which basically is a mixing assay with normal pooled plasma, and it assesses after incubation the residual factor 13 activity, so very much like a hemophilia inhibitor testing. And then the last test for diagnosis of factor 13 is to do the genetic testing to actually know if the deficiency is in the A subunit or B subunit, and that's important because there are some therapeutic implications. Next slide, please. So this picture is of a thromboelastogram, and as you can see, the white line here depicts a patient with factor 13 deficiency. And although we know that 13 is important for anti-fibrinolytic activity, we can see that all aspects of coagulation are affected. And the green line is indicative of a patient who had the replacement therapy. So that's actually the normal, how a normal TEG curve should look like. So although this is useful in screening, it does not specifically tell you that this is because of factor 13 deficiency. So a TEG may provide a clue, but does not, again, tell you specifically that this patient has factor 13 deficiency. Next slide, please. And this I put just for a reference. This is the ISTH SSE actually recommends very specifically an algorithm that we should follow. And essentially, it just summarizes what we talked about, that the factor 13 activity should first be carried out and then followed by the antigen mixing study to look for an inhibitor, and then also look for the genetic testing. Next slide, please. So treatment of factor 13 deficiency. It is relatively easy to treat factor 13 deficiency because it has a very half-life, and the half-life of factor 13 is about 10 to 14 days. Depending on the resources available, fresh frozen plasma, cryoprecipitate, and then factor 13 concentrate provide options for treatment. Obviously, in resource-poor countries, FFP is a good source of factor 13, and in fact may be used in an emergency basis. So if there's a suspicion or that there's a newborn who has intracranial hemorrhage and has to go in for say neurosurgical procedure, one can actually give FFP to treat this patient empirically. Next slide, please. This slide summarizes the recommendation for treatment guidelines, and essentially FFP can be given in the dose of 10 ml per kilo. Cryoprecipitate is 1 bag per 10 kilos. And here, if you just click on the next slide button, I want to sort of highlight that for successful delivery during pregnancy, it is important to maintain a level of about 12%. And therefore, factor 13 deficiency should be treated at centers where one can actually measure factor 13 levels. And if you can't measure it, at least one should be able to send it out to a central lab where these levels can be measured. And the levels should be checked either every week or every 2 weeks to ensure that steady state about 12% is achieved. During labor, we need a higher level of factor 13 of about 35%. And for prevention of postpartum hemorrhage, it's important to give 250 IU early in pregnancy, and then for labor and delivery, a booster dose of 1,000 units should be given. Next slide, please. Now, as I mentioned before, it is important to test for whether the deficiency is due to A subunit or due to B subunit. And this is important, especially in the United States, because there are some therapeutic implications. So in the US, currently there are 2 factor 13 concentrates that are available. The first one is recombinant factor 13. However, this consists of only the A subunit. So this can be used only in patients who have the A subunit deficiency. On the other hand, the plasma-derived factor 13, this is also available in the US and is licensed, has both the A and the B subunits, and therefore the plasma-derived factor 13 can be used in both A and B subunit deficiency. Next slide, please. So over the next few slides, I'm just going to discuss the role of platelets in pregnancy. And as we all know, pregnancy is associated with a number of physiological and pathological changes that occur in platelet numbers and platelet function. And when we look at the pregnant population, we see that about 8% of the pregnant women, the platelets decrease to less than 150,000, and this is called as gestational thrombocytopenia. A variety of research has been carried out, and several reports are available that look at platelet activation markers during pregnancy, and the reports are very variable. Platelet hyperaggregability, hypoactivity, as well as no change in platelet function has been demonstrated. And this just reflects the different techniques that are used for platelet aggregation and the variability that occurs because of that. However, we do know that platelet activation plays an important role in the pathophysiology of the hypertensive disorders of pregnancy. And in fact, the commonest disorder of platelets in pregnancy is ITP, which actually we won't talk about today. Next slide, please. So as we all know, platelets are highly complex organelles and have a variety of receptors on their cell surface. Next slide. And a variety of defects have been described. Next slide, please. Next, yeah. And a variety of inherited platelet defects have been described affecting these receptors. So I'm just going to concentrate on Glanzmann's and Soulier today. However, there is one study that has looked at all platelet disorders, and amongst that, Glanzmann's thrombocythemia was the most commonly associated with morbidity and mortality during pregnancy and postpartum period. Next slide. So as Meera mentioned, that an individualized treatment plan needs to be developed for every patient who has an inherited bleeding disorder. However, these are general guidelines for management of pregnancy in women with platelet function disease. And in general, patients who have severe platelet function defects should be managed by a multidisciplinary team, and there should be crosstalk between obstetrician, hematologist, and anesthetist. They should, if preferably, be treated in a tertiary care unit. In areas and communities where high consanguinity is present, the father should also be screened because this may have implications for the newborn. And then prenatal diagnosis could be offered if both parents are found to be carriers. During pregnancy and delivery, patients may develop antiplatelet antibodies, and these have implications not only for management of the pregnant woman, because if patients develop antiplatelet antibodies, they become refractory to platelet transfusions. However, some of these antiplatelet antibodies may actually traverse the placenta and may in fact affect the fetus in utero, resulting in alloimmune thrombocytopenia. And therefore, pregnancies with at-risk fetuses should be managed in a tertiary fetal care unit as well. And then appropriate hemostatic cover should be given not only during the third stage of labor to minimize the risk of PPH, but also consideration should be given for the 6 weeks of the postpartum period. In general, regional anesthesia is contraindicated in women, and as of now, the safest mode of delivery is unknown and should be taken on an individualized case-by-case basis. Next slide, please. So as far as Soulier syndrome is concerned, it is a rare disorder of platelets, again, an autosomal recessive condition, and it is characterized by abnormalities, either qualitative or quantitative, of the glycoprotein 1b9-5 complex. And we currently have actually just one report of a systematic analysis of 30 pregnancies in 18 women, and 33% of these women had postpartum hemorrhage, and 40% had secondary postpartum hemorrhage. Also, alloimmune thrombocytopenia was found in 6 newborns, in infants born to these women, with 1 intrauterine death because of intracranial hemorrhage and 1 neonatal death because of intracranial hemorrhage. And as I mentioned before, the recommendation is that the women who become pregnant should be monitored for the development of anti-HLA and glycoprotein 1b antibodies to identify fetuses at risk. Treatment during pregnancy consists of giving either DDAVP, antifibrinolytic agents, especially in the postpartum period. Recombinant factor 7A has been used, and rarely HLA-matched platelets have been used. And the reason to use matched platelets again is to prevent alloimmunization. Next slide, please. So patients who have Glanzmann's thrombocythemia and pregnancy, again, there is one systematic analysis, and Glanzmann's thrombocythemia is an autosomal recessive disorder. This is caused by the deficiency of glycoprotein 2b3A, and it's a much more severe bleeding disorder as compared to Soulier. And in fact, many women may not become pregnant either because of significant menorrhagia, hemorrhagic ovarian cysts. Many of these patients need to be on high-dose birth control just to suppress their menstruation. And again, in Glanzmann's, early pregnancy loss is very common. And as of now, there aren't very good recommendations of how one can manage platelet transfusions or other treatment around the implantation period. So this one report of 40 pregnancies in 35 women has shown that intrapartum bleeding is much higher, again 61%, while primary postpartum hemorrhage was reported in about a third of pregnancies and secondary PPH in about a quarter of pregnancies. Again, maternal alloimmunization reported in 73% of pregnancies, and neonatal alloimmune thrombocytopenia thus far has caused 4 neonatal deaths. It's important to remember that DDAVP is quite ineffective in patients with Glanzmann's, and either treatment with recombinant factor VIIa, antifibrinolytics, and then when necessary, HLA-matched platelet transfusions is given. Next slide, please. So this is my last slide, and I actually did not know that we had these many data for the use of DDAVP in pregnancy. And thus far, about more than 200 pregnancies have been treated with, or women have been treated with DDAVP, and this has resulted primarily in a very successful pregnancy. And there has only been one report of preterm labor and one report of water intoxication during pregnancy. So I won't go through the details, but I've put the reference down for anyone who needs more details. I think this is my last slide. Next slide. So I just want to thank you, and I'll turn this over to Kerry.
Thank you very much, Dr. Rajpurkar. And I'd like to thank both of our faculty for their excellent presentations today. For participants who are interested in receiving continuing education credit, instructions for how to apply for the credit will be emailed to you shortly after this webinar has been completed. Next slide, please. At this time, we will proceed with the question and answer part of our program, which will be handled by our Executive Director, Dr. Anne-Marie Nazaro. And as a reminder, participants can submit their questions via the chat box on your GoToWebinar control panel. Questions will be answered in the order they are received. Dr. Nazaro?
Thank you, Kerry, and I want to thank our wonderful faculty today. We have the two first questions are for Dr. Rajpurkar, and I will just get right into them. They both come from our colleagues in Texas. And the first is, in your opinion, how clinically important is it to identify patients with mild factor XIII deficiency, heterozygosity? If someone has a factor XIII activity of, for example, 30 to 50%, does this change the management approach in any way?
So as I mentioned before, there aren't many studies outlining at what level exactly is needed for successful maintenance of pregnancy. So I would suggest that if there is a research study at your center, that much more data are needed. So I think we need a registry for patients who have mild factor XIII deficiency. And in fact, many centers don't test factor XIII as part of their routine evaluation in patients who present with miscarriages or patients who present with heavy menstrual bleeding. So I don't think we have the exact answer yet.
Thank you. The second question is, in a patient with menorrhagia or heavy menstrual bleeding, as ACOG likes to say nowadays, and no other significant bleeding symptoms, how do you interpret a factor XIII activity of about 40%?
Yeah, and I'm going to go back to my first answer that I think we need larger data pool to analyze and be able to come up with a specific answer. However, if we find that the factor 13 level is decreased, I think it's worthwhile at least getting the genetic testing to see if there is a deficiency in A or B subunit. And secondary, I think other supportive management, such as the use of hormonal supplementations or antifibrinolytics, should be carried out.
Very good. And we have a couple of more questions. This one is, can you please comment on the etiology of gestational thrombocytopenia?
Yeah. I think, the question really is, when larger studies have been done, the bone marrow seems to be active in women who have gestational thrombocytopenia. So the hypothesis is that perhaps these sort of small placental particles that take place or that find their way into the maternal circulation, whether there is activation of the coagulation cascade and a little bit of consumptive process. However, having said that, in patients who have gestational thrombocytopenia, they're no more at a risk for adverse event from thrombosis than women who don't have gestational thrombocytopenia.
Thank you. And this one, to either one of you or both of you, there was a great deal of information presented today, and one of the questioners added necessary information, and I hope we can easily access this again. Is there any other way that we can pose a question to on rare bleeding disorders if we find ourselves in a situation, if we wanted to reach the foundation or the faculty presenting today?
I can take.
Go ahead, Meera.
Oh, sorry. I can take that question. And I just wanted to say that the foundation has an excellent website that you can go to, and questions can be posted there. They have an Ask the Expert spot where you can put your question in, and then the questions will be directed to the appropriate experts who will then get back to you with an answer very promptly. In addition to that, we will be posting all of the references of today's presentation on the website, where you can have easy access to the references. You're more than welcome to try to reach us. We are very open to talking to people, and you can directly get in touch with us either through our email addresses or through the foundation.
Thank you so much, Madhvi and Meera. And I believe this concludes our question and answer period. We want to echo the words that Meera just said, that please visit our website, revisit this presentation and the source presentation as well, which is a variation of this through Dr. Diane Nugent. You have both of those resources on our FWGBF, as in foundation, WGBD.org. And we have the Ask the Experts feature there, as was just said. Thank you so much for joining us today. And I believe this concludes the webinar, the Q&A, and our heartfelt thanks to the wonderful faculty and to my Director of Education, Kerry Funkhouser. Thank you all.
Thanks again. It was a pleasure. Yep.
Thank you very much.
And our audience. We appreciate you.
Okay. Bye now.
Bye for now.